post-op, which is I found very interesting. We saw him today for something else. He's got heel pain, but he had hallucis limitus in his first metatarsal, and this is how many years? When did we do this surgery?
June 2013, I believe.
June 2013. So now we're at 7 years post-op for his hallucis limitus. What I did is a minimally invasive procedure. Really can't see where we did it. But basically what I did was I removed the bony spur through a percutaneous incision here, and we did a V osteotomy in the metatarsal head shaped like this, so it pushes the head upwards. And the V-shaped osteotomy here, or actually a V-shaped wedge we take out. So we take a wedge out of this and a wedge out of that. I'll show you the cartoon picture of that and the video as well. I'm going to show you first, as you can see with this model here, we've got a lot of arthritis in here. What we will do first with this, usually we make our incision kind of right around here, and we free all this soft tissue around. And then we take a 3-1 burr and burr the arthritis out. This is kind of exaggerated with our model here. So what I'm going to do now is just going to cut this off and show you what we do steps as we go. You can see this particular has arthritis in the top here. And so what we're going to do is kind of make some osteotomies to relieve the joint, so the joint moves better too. So this is the first step. After we get the, we burr this down. And we're going to burr this out. This usually make an incision about here, and we just burr all this down. You can actually reach over the bone and get all this smoothed out too. So that's done in kind of a sweeping fashion. So you'll be at this area here, and you'll be just getting this out like that. So after we make our incision, we take our burr, enter through where we at, and we're basically going to take off the medial prominence and the arthritic joint, and then we're going to reach over. If it's too far of a reach, we can make an additional incision here and smooth this off right here. Now you don't have to use the 3-1 for everything. You can use smaller burrs and everything in case you run into an area where you're getting trapped in some soft tissue. Smaller burrs can work too. That's kind of what you want like that, and just smooth down the arthritis out. Now next thing we're going to do to relieve the pain in this, we're going to make a cut. It's going to with the apex at the top, and a cut that actually kind of goes this way. We're going to cut it away in an oblique fashion, leaving the plantar cortex intact, so that this will close the bone up like that and give us dorsiflexion of the head. Okay, so once we have the spurring of the joint off and the arthritis, we're going to make an osteotomy in an oblique fashion like this. We're going to leave the plantar aspect intact. So that's done through the same incision that we had here, where we took off the bony spurring. So from that area right here, we're going to go in and start making our osteotomy like this. Again, about that angle. Now this is not really movement this way in a real foot, but I'm just going to show you the osteotomy. So the osteotomy is going to go down like this. And you're going to feather the actual plantar cut so this begins to move up. This is done a lot slower than that too on a real patient. You won't even hear this. It'll be a very slow movement, kind of like this. So once that begins to kind of move up, you can see it moving up now. So we're kind of done now. So that going from there to there. I'm going to leave that little wing, that little plantar cortex intact. So when a patient stands, this doesn't require fixation. It's going to push that in. Now to increase the motion more, we'll do the same kind of cut here with our Aiken. And I'll go ahead and form that for us. So we do this from a medial approach, and what I normally do is go straight through my first cut like that. What I normally do. and then I'll make my wedge from the plantar aspect like that. So now when you're doing this, it's better to make kind of a reciprocating motion. The burr cuts better like that. Once I have that, I'll just show it to you, clean it out so you can see what it is. You can see it like that. Then we start again making our same position. We begin to feather that bottom to where it's closing. So we're going to leave our cortex intact on both of the plantar cuts. I'm going to do this a little faster. This doesn't work. It works good in bone this slow, but it won't in this model. So you want to, once again, you don't go fast with the burr. You don't even want to really hear the burr when you're doing surgery. So once that's kind of feathered down, what you'll see is this will close, and then this will close. So both of these will close like that. And now what it does is angles your toe up a little bit, but it doesn't take, you're still going to have weight bearing surface here for the first minute. So this just opens the joint and allows this to move more, and also you don't have to move dorsally as much. So that's why this works with hallux rigidus. Usually around stage 2 or 3. Once you're at stage 4, you have to kind of do other things to the first ray. You may have to fuse the joint or actually put an implant in. But this is a good technique up to about stage 3. So this is kind of interesting because if you look at it, even when I load his foot, he's got good range of motion in this foot even that far out. Now before we did the surgery, you didn't have much range of motion?
Not like I used to. In the last year of it, it had become rather
painful every day.
Yeah.
it's still. So before we did this, he had, he has hallux ligaments and began to be painful. And so this is interesting. We're looking at him basically since that would be 7 years ago, wouldn't it? Pretty much. Okay. So if we get a kind of a quick range of motion, this is not exactly scientific, but we're going to kind of look at what we got for our range of motion. If you look at our numbers on there, then we'll push him up. A range of motion, dorsiflexion without making him hurt, about 35. Keeping that still, 35 dorsiflexion. Plantar flexion, about 35 as well. So dorsiflexion and plantar flexion got a total range of motion of 70, and that's within the normal range for somebody that has, that'd be even for a normal foot. So after 7 years, he's still doing well with this. And today he's come in with a heel pain. That's got nothing to do with it. This is kind of an unusual time for us. We're right in the middle of that COVID thing, so so it's a little unusual. But that's why I'm wearing a mask the whole time during the filming here. But he's doing well. Let me ask you this: before you had this surgery, if you can remember that far, how bad was this on a day-to-day? From 0 being no pain to 10 being a lot of pain. What would you say?
In the last year to year and a half before surgery, it became a daily affair. The wrong step produced agonizing pain.
Yeah. And now on your day-to-day, you work, you're employed, you work a lot and all that. What kind of pain do you have daily now?
Not too much. Just average foot thing after lots of exertion, that sort of thing. But as far as the original problem, no. No.
Okay. Good. So we got a successful surgery and long-term result here. And a lot of times we patients once they're better, we don't see them back. And so we have an advantage of him coming back for something else. To look at this right here. So he was gracious enough to give us some time to do this. And now we're going to address his heel pain. Let's see.